And good evening, everybody, and welcome to Prostate Forum. Today, we have an expert from Toronto, Canada. We welcome in Brian Wodlinger. I hope I'm doing that right. Is it close? With Exact Imaging. And we have a treat for you in that we're going to be talking about micro-ultrasound and micro-ultrasound as an alternative, perhaps someday, perhaps now, to MRI. For those of you who are claustrophobic, this is the kind of thing you're looking for. Something that's portable, that can be done in an office, that doesn't involve going into a noisy tunnel. And if we have fans out there of the traditional Doppler ultrasound technology that has been available through a couple of clinics here in California, I'm expecting a vast improvement over that. Dr. Wodlinger is a postdoctoral level biomedical engineer with 15 years of experience in medical devices and biomedical research. Brian is VP of Engineering and Clinical at Exact Imaging, responsible for overseeing product development, clinical applications, physician training, and clinical evidence generation. Prior to Exact Imaging, Brian held research positions at the University of Pittsburgh Medical Center and Case Western Reserve University. His research won Popular Mechanics Top Breakthroughs of the Year award. He holds a PhD and a master's in science in biomedical engineering from Case Western Reserve University and a bachelor's of science in engineering from the University of Toronto in Canada. We are glad to make this international and welcome you, Brian.
Thanks very much, Neal. You did really well on the last name. I know it's not an easy one. Let me just share some slides. What I want to talk to you guys about today is this new technology, micro-ultrasound, and why it's important to be able to see the prostate better than we have been able to in the past. And just to start off, I'm the wrong kind of doctor here. So Neal gave a great intro, but I have not made my grandmother proud. I'm not a physician. I'm a biomedical engineer. I have a PhD. I'm going to be talking about clinical data and clinical evidence, and I'll interpret that as an engineer would and someone who designs ultrasound machines. But I'm going to try not to give any medical advice, and please don't take any of the things that I say as medical advice. If you have questions about your particular situation, then I always recommend talking to your physician. All right, you all know the types of imaging that we have in the prostate cancer workflow, probably as well as I do. The most typical ones are conventional transrectal ultrasound and MRI for the past 15 years or so. And unfortunately, there's problems with both of them. Conventional ultrasound can't see most cancers. It has a terrible sensitivity of about 50%, although as you mentioned, Doppler improves that a little bit. And MRI is not real time. Many men can't take advantage of it because of kidney function or implanted devices or claustrophobia. And even with all of that, it still misses some cancers. And that's a problem in a few different ways. It's a problem for initial diagnosis because it means we still need this systematic biopsy. We can't trust the MRI to give us a good enough negative answer that we can avoid biopsy in a lot of cases. And it's also slow, it's expensive, there's 2 visits, you need contrast injections, you have to find specialized radiologists, which is not terribly difficult in California, but can be difficult in other parts of the world. And you need these fancy fusion machines. And if anything goes wrong in the fusion procedure, or the person's not an expert in doing fusion biopsy, you can get kind of suboptimal results. It's also not ideal in active surveillance. So what we'd like to be able to do is an imaging-based surveillance where you undergo serial imaging and we can be safe detecting progression of disease based on the imaging without the need for periodic biopsy. And MRI is better than what we've had, but it's still maybe not good enough for most cases. The most common progression is grade group 1 to grade group 2 on active surveillance. And in that case, this paper, I just pulled a random paper from 2020. There's a number of them on this topic, but they showed a negative predictive value of about 76%, which translates to about a 1 in 4 chance of missing progression. and a delayed intervention. It's also not ideal for treatment and post-treatment. So ideally, we would use imaging to make sure we had the right candidates for focal therapy, to make sure we were targeting the right locations, and to make sure that we could follow up and that the cancer was completely treated and detect any recurrences early after therapy. And neither conventional ultrasound nor MRI nor the combination of the two can really do that very well. The MRI is much less accurate after focal therapy or radiation therapy than it is up front. And it's also probably not enough to detect surgical margins either, although it's helpful. So some surgeons do use it for guiding their surgery, for deciding whether or not they can be aggressive and do an aggressive nerve sparing on radical prostatectomy. But the sensitivity and specificity are not ideal for ruling out that kind of disease. Okay. And everyone, please, this is a nice small group. Feel free to interrupt with questions. I'm very happy to make this into more of a discussion. Okay. So we need better imaging. And because I'm an engineer, I get to talk about the physics of micro-ultrasound, whether you want to hear it or not. And what we did was we said, how can we make the ultrasound better? If the problem is the ultrasound can't see the cancer, what can we do to help ultrasound see more of the prostate? And we did it by increasing resolution. And I'll talk about why we took that approach in a little bit, but I think we did a pretty good job increasing the resolution. We increased the frequency from 9 megahertz approximately to 29, so about a 3-fold improvement in frequency and about a 4-fold improvement in crystal packing on the transducer itself. That translates to about 12 times the amount of information in our images compared to others. And it looks different. So on the left here, you can see a conventional ultrasound image. And in the center is the micro-ultrasound image of the same slice of the same prostate. Okay, this is exactly the same person and the same part of the prostate being imaged with the two different techniques. And there's much more detail in the micro-ultrasound image than in the conventional. The MRI is on the right, just for comparison. But in the micro-ultrasound, you can appreciate here in this zoomed in box that there's a cancer here. It's a Primus 4 modeled cancer. And it ended up being a 4+3 grade group 3 prostate cancer with extensive cribriforming. And you can't see it at all on the conventional ultrasound, which isn't a surprise. It is a bit surprising you can't see it on the MRI, but this is the type of added detail that we were looking for. And we think it works because we're able to see the prostate ducts. Prostate's a ductal organ. It's basically a big sponge. And the individual ducts are about 100 microns in diameter, really small, much smaller than conventional ultrasound can see. So by increasing the resolution to about 70 microns, which is what the system does, we start to see things like this. So this is a Primus 1, we call it Swiss cheese or spongy pattern tissue, and it looks a lot like the normal ductal pattern that Gleason reported when he was reviewing prostates under the microscope in the pathology lab. And he came up with this system that was entirely based on visualizing the way the ducts broke down as prostate cancer took hold of the tissue. And it looks very similar to what we've observed going from well-ordered ducts to these cases like this. This is a Primus 5 where there's absolutely no ducts remaining in this part of the prostate. It looks very smudgy and modeled and irregular. And so we think that it works because you're able to visualize the detailed ductal anatomy in almost the same way that a pathologist would under the microscope in real time. And we validated this with the good folks at UCLA, which has an incredible urology and bioengineering department. And one of the brilliant young bioengineers, Jake Pensa, led this work to scan patients before radical prostatectomy and then take the individual slices of the prostate, put them through a scanning histopathology lab so that we could scan the whole mount, slices, and actually count the individual ducts using some very fancy image processing and measure them so that we could generate this beautiful histogram to show what percentage of the ducts in the prostate were visible in micro-ultrasound. And it's 95% compared to 15% with conventional ultrasound. This supports the idea that it's being able to see these ducts that gives us the advantage in seeing prostate cancer in real time. And I don't know how many of you are familiar with this, but in conventional ultrasound, cancer, when you can see it, looks very dark, looks like a black hole in the prostate. And in micro-ultrasound, we were very surprised to see that it doesn't. We actually see a number of different patterns because we're not just seeing the extra attenuation of the signal, we're also seeing a breakdown in the ductal structure. And then sometimes it looks like this is a starry sky pattern where we have these little punctate foci in tissue that has no ducts anymore. And sometimes it looks like this with this kind of smudgy mottled pattern and also no ductal structure. There's a few of them. We actually have a whole protocol on how to interpret these images called Primus. And it's now been validated. Primus has been validated in both the peripheral zone and the anterior zone and transition zone, so it can be used everywhere in the prostate and seems to work quite well. We designed it with a 5-point scale, very similar to PIRADS for MRI, if you're familiar with that. So it's easy to talk about Primus and PIRADS risk levels because they use the same scale. And all that's great. I think the system would have been very useful even as it was originally designed. But as any of you who have done any ultrasound, higher frequency ultrasound doesn't penetrate as far into the body. It's only useful for very shallow organs. And at 29 megahertz, everyone said, oh, you'll be able to image 2 or 3 centimeters maybe. And that wouldn't have been very useful. We would have been able to get the peripheral zone of the prostate, but we wouldn't have been able to get the whole prostate. So the real advance that makes this system clinically useful, that makes it viable, was being able to take high frequency ultrasound and make it go deeper into the body. And that breakthrough came in 2023, just a couple of years ago. And these are some examples. So now we can image 6 centimeters into the body, which is enough for about 200 cc prostates, about 200 gram prostates, which is pretty much everybody. These are examples of 150 cc prostates. All 3 of these are about 150 cc's. And here's a nice anterior lesion in one of them that we can see quite well. And since we're designing an imaging system, we made it a real platform technology. It can handle transrectal biopsy. It can handle transperineal biopsy. Here's an example of both. It can handle fusion. It can handle going without fusion. Okay, so it's useful in a lot of different scenarios for a lot of different practitioners, regardless of what they're doing at the moment. Okay, so we can see more. What can we do with that information clinically? Okay, because this is not useful if we can't actually make good clinical decisions with it. We're going to talk now about some clinical evidence, which are studies that have been done on the technology in real patients. We have about 80 to 100 of those to date in the clinical literature. And I'll start with one on screening. So this is to decide whether or not a man needs a biopsy. Okay, so they generally present with an elevated PSA or an abnormal digital rectal exam. This study was led by Laurie Klotz at Sunnybrook Hospital here in Toronto and included 11 institutions from around the world. And it was a registry, and they enrolled about just over 1,000 subjects. And we were interested in whether the micro-ultrasound prediction of whether or not this prostate was likely to harbor cancer differed from the MRI prediction. And this was the first time where we compared the two, and micro-ultrasound did better in a number of ways. The sensitivity was higher. We had a sensitivity of 94% versus 90% for the MRI, and a negative predictive value of 85% versus 77%. So this showed that micro-ultrasound was actually better at selecting men for prostate biopsy safely than the MRI. And of course, the next interesting question is, if I can select men well for biopsy, can I perform a good biopsy? Is my cancer detection rate similar? And this has been studied pretty extensively, but here are 4 nice prospective studies on it, and nice blinded prospective studies on it. And all 4 of these studies showed the same thing. The micro-ultrasound did essentially just as well as the MRI fusion system in finding prostate cancer. So based on these results, we decided to go really big. And over the past 5 years, 4 years, we've been running the Optimum study. This is the biggest international study we've ever done on micro-ultrasound and MRI. It was being run at about 20 different centers, I think in 9 different countries. And it's the first randomized trial. So there's different levels of evidence in the clinical literature, different levels of confidence that you can get in designing a study. And this is the highest level of confidence you can build in. And the design of the study was that men who were indicated for prostate biopsy because of PSA or DRE were enrolled. They were not allowed to have had a prior MRI, and this had to be their first biopsy. And they were randomized, and one group got micro-ultrasound alone. You can probably see my cursor over here. One group got micro-ultrasound alone, and the other group got MRI. And those guys that got MRI were further broken down. Some of them were randomized to get biopsy on a conventional fusion machine. So you may have heard of the Euronav or the Coelis or the Artemis. And some of them were randomized to get biopsy on the ExactVu micro-ultrasound machine with the built-in fusion of their MRI results. And we were interested in how the rate of clinically significant cancer would differ between the 3 groups. So it was a non-inferiority study. We wanted to demonstrate that micro-ultrasound on its own was non-inferior to fusion. And I'm happy to report the study actually concluded and was published just in March this year. It was presented at the European Association of Urology meeting in March, and the results were unequivocal. Micro-ultrasound is non-inferior to MRI fusion for detecting clinically significant prostate cancer. It won the editor's choice. It was published in a pretty good journal. JAMA is one of the best medical journals in the world, I think. So it was a really great end to that study. And I'll show you some of the numbers from it. So this is the primary outcome comparing micro-ultrasound with MRI fusion. I showed you those 3 groups that we had. And the bottom line was that micro-ultrasound found about 4.5% more cancer than MRI ultrasound fusion. So the micro-ultrasound group had 47% detection rate, and the MRI conventional ultrasound group had a 43% detection rate. So we met our objective of being non-inferior. We didn't quite make the statistics work for being superior, but we came pretty close. So micro-ultrasound can replace MRI fusion for prostate biopsy without any risk to the patient. That was the bottom line of this study. But what if you already have an MR? It certainly doesn't decrease anything. It doesn't show it here in the rounded numbers. There was about an extra % or 2 improvement when you added the 2 together. So it's still worthwhile if you happen to have an MRI or if it's easy to get. And for men with an MRI, there are still advantages to combining the technologies. So the Optimum study showed an increase in detection rate when the biopsy is done on ExactVu. But also, once you have an MRI, sometimes there's a problem where the MRI is negative, but there's a continued suspicion of disease. So for example, the PSA keeps increasing, even though the MRI is negative. And this has been investigated by a couple of groups in Canada and Italy, and they both had problems with patients like this, and they didn't know how to biopsy them because there was no target. So rather than doing a systematic biopsy, they did a biopsy with micro-ultrasound, and they found targets, and they showed that actually the micro-ultrasound was quite useful in the case of negative MRI in finding some of these MRI invisible cancers. And similarly, there's often a concern with PIRADS3 patients. So patients who have an MRI and the MRI is equivocal. It's not high risk for cancer and it's not low risk for cancer. It's the I don't know bucket. And in these patients also, we were interested to know whether micro-ultrasound would be able to see anything, because maybe cancers that are equivocal on MRI would also end up being equivocal on micro-ultrasound. But in fact, that wasn't the case. We found that the Primus system was actually able to separate out the men who needed biopsy from the men who didn't quite well, in this case, too. This is more of a topic in Europe where they're trying to avoid biopsy in PIRADS 3. I think that's less common in the States. So that's detection, initial detection of cancer and screening. On the active surveillance side, there's also been a couple of nice studies, also out of Italy and Canada. And they found that actually micro-ultrasound might outperform MRI in detecting progression on active surveillance. Here's just a couple of examples. You can see micro-ultrasound had a very nice 97% sensitivity for finding cases of recurrence or progression rather on active surveillance. And in this case, the table is much more complicated, but the micro-ultrasound based procedures were much better at finding cases of progression than just the MRI targeted or the systematic biopsy. What about treatment? The initial data suggests that micro-ultrasound is very good at detecting recurrence post-treatment, but this is still very new and we don't have a lot of data on it yet. It promises an easier imaging-based follow-up if we can make this work and show enough sensitivity here. And we have some interesting examples though. So this is a kind of a neat one. This is what the prostate bed looks like after a prostatectomy. So there's the bladder neck over here, the spongy urethra up here. This is the prostate bed where the prostate sat. And this is a case where there was a concern for recurrence. And the patient was imaged and everything looks totally normal. Doesn't look like there's any sites of cancer growing in this area. And sure enough, the patient was just fine. Here's another case where things weren't so good. This is a recurrence post-HIFU. This was biopsied and found to be a recurrent grade group 2 cancer. But on the bright side, it was found very early because of the imaging. We were able to do a targeted biopsy of it, and the patient was able to undergo a repeat focal therapy procedure to eliminate this cancer that was probably on the margin that wasn't treated as well as it could have been. On the surgical planning side, there's actually 3 studies already showing that micro-ultrasound may have an advantage here as well, which isn't very surprising. We can see the capsule of the prostate in great detail. So seeing small deviations or interruptions in the capsule is much easier on micro-ultrasound than it is in other technologies. Here's some examples of what it looks like. This is a lesion, and the red arrows show a break in the line of fat between the prostate and the rectal wall. And here's one on the anterior side of the prostate. You can see there's this nice hyperechoic bright border of the prostate everywhere except this area beside this anterior cancer here. The sensitivity and negative predictive value, not perfect yet, but quite good considering this is very early work. And this is intended to help physicians be more confident in recommending nerve sparing to patients undergoing prostatectomy so that we can avoid positive margins and recurrent disease. All this work together has resulted in inclusion of micro-ultrasound in several sets of clinical guidelines. So we've got the NCCN guidelines, the National Comprehensive Care Network in the United States, which has a very nice statement, has had a very nice statement actually for a few years already, saying that micro-ultrasound performs similarly to MRI. But we also have inclusion in the EAU guidelines, the European guidelines, and also in the AFU French guidelines. And I expect all of these will be reviewing with the publication of the Optimum trial now, and will be updating their guidelines the next couple of years. So just to conclude, short talk, but I think it's not controversial to say that modern imaging is critical to making good decisions in prostate cancer, whether it be micro-ultrasound or PSMA PET or any of the other new technologies. When you can image these things, it impacts a number of different steps in the prostate cancer pathway, from screening, initial diagnosis, surveillance, therapy guidance, detecting recurrences early, and all of those things make, I think, the prostate cancer journey hopefully a little bit easier and help to improve some outcomes by treating early and treating correctly to the risk of the disease. Any question?
Yes, I have a couple of questions. Thank you, Brian. That's absolutely critical information. We've been waiting for this modality for a while now. I think this is going to put a lot of the stuff back into the office where it presumably belongs, rather than dealing with MRIs and getting them approved and all that stuff. When is this going to be available to be put into regular doctor's office or regular urologist's office?
It already is. The system's been FDA cleared since 2017. We have about 300 systems around the world now, I think, including about 100 in the United States, quite a few in California already. And but I agree, the optimum trial and the inclusion in the clinical guidelines, I think, is really a big step. We've been waiting for this level of data for a long time.
Yes. Are you got any concern about the guys in the office not being radiologists trying to read these things? I know radiologists can't agree on MRIs, let alone other things. And is there any place for artificial intelligence in this?
Those are good questions. We were very concerned with urologists being able to read this initially. And we actually did a study on it. It's published in the SIUJ a couple of years ago now. But we have a very formal training program. My board of directors is very keen on this idea that if people don't use the imaging correctly, it seems like the machine doesn't work. And so we need to make sure everyone uses the machine correctly and interprets the images correctly. And so we have this formal training program that we give away free to everyone. And it includes some online modules to learn how to read the images. And then we come out for the first cases. And there's a follow-up certification program even after we leave. So we're there for probably the first 15 cases, first few days or weeks of use. And then we follow up over the first 100 cases to provide offline review and make sure that the physician is interpreting the images correctly. And I'm happy to say it seems to work very well. The training program results that we published are really excellent. And we haven't had anybody yet fail out of the program. So everyone who's gone through the program has been able to learn it and learn it really well and get the same level of results that we've seen in all of the other publications.
And then anything with artificial intelligence and reading these things?
Yes, we are actively working on artificial intelligence. I have about 5 papers published in the engineering literature already about how to interpret these images using machine learning techniques. We have some excellent partners at UCLA, at University of Florida, at Queen's University in Canada here, and University of British Columbia. And they've been working really hard applying some really cutting edge stuff, because ultrasound images are more difficult to apply AI to than other images. There's more artifacts and it's more user dependent. But so far it seems to be working very well. And now that we have this big database from the Optimum study, I expect we'll be seeing an AI assistant to help physicians along the learning curve and give them a second set of eyes over the next couple of years.
Yeah, I think that's an excellent idea. How about if you use this micro-ultrasound for a testicular mass? Is it better for other types? We used it to see the prostate volume, post-volume, post-void residuals, and what the testicles were doing if they had some. And is it good for that too?
It probably is. The testicles are a particularly interesting example because the seminiferous tubules are not that different in size from the prostate ducts. They're actually quite similar. So we think it's going to work very well. There's a researcher who was at Hopkins and actually just moved down to, I think it's Baylor in Texas, who's been looking at this for a couple of years and has some very promising results that he presented at the AUA just a couple months ago.
And then how about approval from Medicare?
So the system is currently reimbursed the same way as conventional ultrasound, which means that if a physician offers it, they can bill the same reimbursement codes as for a traditional ultrasound procedure. And ultrasound is already approved as medically necessary in the case of prostate cancer diagnosis. So everybody is not getting paid more than for conventional ultrasound, but still getting reimbursed for the technology already. In order to get more reimbursement for the physicians. There's some work that still needs to be done on the structure of the reimbursement codes, because right now there isn't a targeting code for prostate biopsy. It's the same for MRI and MRI fusion, actually, and it makes it difficult for groups to adopt that technology as well, you can imagine.
Yeah. That's a fantastic talk. And boy, we've been waiting for this for quite a while. I sure wish I would have had this when I was actively working. Maybe I could try it on some of my neighbors. I'm not sure. But
Brian,
There's one in your area. You could probably talk Wayne into letting you try.
sure. This
that's
is
a nice
Newport
segue,
Beach,
Brian. You mentioned that there's many opportunities to use the technology in California and in Southern California. Will I find that online, or can you?
Yeah, so we have an online physician finder.
Okay.
If you go to our website, exactimaging.com, there's a physician finder link up at the top. Pretty much every UC, I think, and many of the VAs now have adopted the technology as well. In Southern California, also, I have to give a bit of a plug to Paul Datto in Genesis Urology in San Diego. He's been an expert. I think he may have been the first expert in California on the technology. He's just a fantastic guy down there.
Okay.
Yeah.
So we'll post that information on the website, because there was certain to be follow-up and questions. So
Absolutely, and I shouldn't neglect Wayne Brisbane as well at UCLA. Also an excellent guy and also a leading researcher in micro-ultrasound. I believe he's taking part in there's two follow-on studies to Optimum that are active now. Music AS, looking at micro-ultrasound for active surveillance, and Music Screen, looking at micro-ultrasound for screening. They're both randomized trials also in these other uses for the technology. And I think he's taking part in both.
great. Thank you.
very good.
Brian, thank you. We are fortunate tonight to have a large segment of our audience is both past and present advisors and directors at Prostate Forum. And there's someone I know that usually has great questions. And what I'm going to do is I'm going to go down our list and I'll ask, and then I'm going to go last because chances are our directors and advisors will have some, we'll ask my questions before I do. Ira, how are you doing tonight?
Hi. What is the cost of this machine?
It's priced similarly to other high-end ultrasound platforms on the market. I think the cost is somewhere around $200,000 US,
And
depending on the configuration.
excuse my ignorance, but what does an MRI machine cost?
Several million usually.
Several. Oh, that's right. That's right. And then you mentioned, I think, Wayne
Brisbane, Dr. Wayne Brisbane
He
at
does
UCLA.
focal therapy, if I remember correctly.
He does, yes. That is one of his many research interests.
So I guess he uses this for the focal therapy.
I don't know if he started doing a combined therapy program yet. I think a lot of his therapy is using HIFU. And obviously you can't have two transducers in the rectum at the same time. So a lot of the time the micro-ultrasound is used for guidance and planning prior to the HIFU therapy, but it's not used during HIFU therapy. It is used during other therapies. So we do real-time guidance of laser ablation, of cryotherapy, and of IRE, but not HIFU.
Just a brief correction, Brian. This is Southern California, and a lot of the men, two transducers would fit just fine.
Let's ask our CTO, is that staying in, Brian, or is standards and practices taking that out?
What's that? Sorry?
I'm asking Brian McAvoy.
Brian. Yeah.
What are you asking?
Dr. Metzger's comments, is that staying in or is standards and practices taking that out?
Oh, it's Dr. Metzger. It's going to stay in.
Okay. We'll just show it after 10 tonight. Ira, I know we started with you. Do you have any other questions?
I wonder specifically which institutions in Southern California besides San Diego have this machine.
Oh, I don't have a full list on me.
I'll
Don't
look
quote
it
me
up
on it.
later on the exact.
Yeah, I mean, UC Irvine, UCSF, UC Davis.
Oh, Irvine has it?
Hmm.
Now, does the radiologist at some of these institutions read it instead of the urologist?
I believe everywhere in the United States is driven by the urologist.
Oh, interesting.
There are some institutions where there's a more of a collaboration than others, but in the United States, it tends to be very urology focused. In Canada, we see a lot of radiologists and urologists working together on these images. Cleveland Clinic actually also, the radiologist there has been fairly heavily involved in helping with the imaging. And in Europe, in some countries in Europe, prostate biopsy is performed primarily by radiologists.
Yes, and
So
that
it
that
really
was
varies pretty widely.
yeah, that was an issue here where the radiologist wanted to take over our biopsy business, but our elbows turned out to be sharper than theirs. Never actually got it. And I can see this moving a lot of this stuff back into the office where I think it's going to be less expensive. It's going to be cheaper. You won't have to wait weeks or longer for authorizations. And I just
Yeah.
think it's going to revolutionize this whole thing.
Yeah, we've seen a pretty big effect in some places in Canada and Italy, both in particular. The waiting times for MRIs are very long. Like at Sunnybrook, it's 6 months
Oh,
for a
my
prostate
God.
MRI, you can imagine. And so being able to even just triage everyone coming in, being able to say, I'm doing a scan right away. As soon as you come in for a consultation, I see a target. You're coming back next week for a biopsy, right? Because I've seen something that I need to biopsy, has really made a big difference in a lot of our centers.
Say, Brian, if a person gets this test and they want a second opinion, is
Yep.
there a center that's more experienced than the others that we could refer these people to?
Yeah, we do have a number of folks that are willing to read micro-ultrasound scans. So our typical protocol is save a nice sweep through the prostate as soon as the probe goes in. And that means we have a record to go through to look at before anything's been done. And those sweeps can be shared. We've had a couple of cases where people wanted second opinions, and we sent them out to another center with an expert reader, and they gave their thoughts.
So we would, if possible, we would like to maybe offline, if you could send us that information so that we could know who to refer these people to.
Yeah, if you want to refer for now to our info line, we have an info@exactimaging.com email address. We're very happy to direct people to the nearest provider or provide recommendations on
Exactimaging.com.
.com.
So that's the info line.
Yeah.
Okay. And I guess that's covered by medical coverage.
The emails are no charge, and me and my team usually answer them. I can't speak to the referrals because a little bit depends on where the referral goes.
That's right, because you're in Canada, correct?
And we do have a radiologist in Canada in particular who's usually open to doing these, but I try not to get involved in any payment issues there.
So if you know of somebody in the United States, probably, and also the name of the person in Canada, if somebody wants to pay out of pocket.
The fellow in Canada's name is Sangeet Ghai. He's a radiologist at the University Health Network here in Toronto. He was one of our first users, and
how do you spell his last name?
Ghai. He was one of the developers of the Primus protocol and was actually also on the panel that produced the PIRADS protocol for MRI.
Okay.
Very smart guy.
Right.
Thanks, Ira.
But having said that, Ira, there are others in the United States, urologists who are also usually willing to read.
Yeah, because that's like we have a support group, and we constantly mention to the people who come to get a second opinion on everything from an expert. We like to do that for this group as well.
Absolutely. It's a good strategy.
Before I ask my questions, I want to go to some of our longtime participants and past directors. Marshall, how are you doing tonight? Do you have any questions for us?
No, Neal, I do not have any questions, but thanks for asking.
Oh, my pleasure. Larry, welcome back. How are you doing? Larry W.
Okay, turned on my microphone.
There you go.
I'm at the other end of the tube in terms of prostate cancer compared to the topic that's tonight, talking about people who are recently diagnosed or getting recently diagnosed. I'm at the other end of the pipe, and I don't really have any questions at this point.
Thank you for joining us. Steve, Keith, would you like to chime in?
Yeah, hi, this is Keith. Actually, yeah, I have a couple questions. Thanks, Neal.
Sure.
So, did I understand correctly that the micro-ultrasound could pick up on tumors that are too small for an MRI to pick up?
Yeah, the resolution of an MRI is usually on the order of a millimeter or two, which makes it hard to find the small 3, 4, 5 millimeter cancers. Our resolution is 70 microns. Those cancers look pretty big on our screen, and so it's much easier to see those. In the data that we've acquired so far on the system, I don't have a nice figure for you to show how the size changes with the different imaging modalities, but typically we think that the system sees those smaller cancers better than MRI, and that makes it very useful, especially in the case of focal therapy, when you're trying to determine what area you need to treat and whether there are any non-index satellite lesions, for example, that might cause problems if left untreated, maybe on the other side of the prostate.
Okay, yeah, interesting. Now, because I'm in a situation where I've had several biopsies that have identified tumors, lower grade tumors, but none of them have ever been visible on any of the MRIs I've had done.
Exactly. It's a very common situation that's you would fit right into those studies that I showed with the negative MRI, but persistent risk of cancer.
Okay, great. I'll follow up on that. One other question I had, this came up recently, a situation where my brother was recently diagnosed. You showed that the micro-ultrasound can visualize the ducts within the prostate at that level. Could it pick up what they call intraductal carcinoma without having to do a biopsy, or is that still something that they have to find?
Yeah, I don't think anybody is willing to trust it yet without a biopsy. Very hard to start a treatment plan when you don't have a really confident tissue diagnosis, I think. But intraductal carcinoma, yes, I do think we can see it. We don't have very concrete evidence on it yet, although it's something that we did collect as part of Optimum and should probably be coming out along with other things like cribriform cancer diagnoses and other Gleason patterns in some of the subsequent analysis on the trial data.
Okay, thanks very much.
Steve, do you have any questions tonight?
I was wondering, you said this machine costs about $200,000. What are they going to do with the big machines, the $2 million ones?
Don't feel too bad for them. There's plenty of uses for MRI machines, right, outside of prostate cancer. They'll see use, don't worry. Here in Canada, we run our MRIs 24 hours a day, 7 days a week. And it's not for prostate cancer, it's for lots of other things. They'll find plenty to do with it.
Oh, okay. That was my only question. Thank you.
Ross, thanks for joining us. Do you have any questions tonight?
I joined and then had some internet connection issues and unjoined and rejoined again. So I got most of the presentation before I got kicked off. I apologize for that if I can.
Welcome back.
Thanks. I find this very interesting and imaging more and more important. I am a prostate cancer patient, and I really found it very interesting about the issues about actually differentiating between, I wasn't sure how until I saw this, how you're identifying the imaging. And you're doing all sorts of image processing to identify specific cancers regions. What's next in the manner that, and it may have been something I missed, but what's next for pushing it further into use and using in those diagnostics?
So I think AI is going to play a big role in the next few years. We have a nice data set now and some good algorithms that we've been working on with other smaller data sets. So I think that's going to help make it easier for people to learn the imaging. We have some other nice projects coming as well, integration into more therapy systems for focal therapy, and some other fancy new ultrasound-based processing techniques to look at more functional imaging in the prostate. So MRI has one advantage over us in that they don't just look at the anatomy. They also look at things like blood flow in the prostate. And that's one thing that we don't do today. Everything we've done so far has just been anatomical imaging of the ducts. And so some functional imaging on things like blood flow, stiffness would certainly add to the diagnostic information that the system provides.
I would add a flavor variation to that question because I think it came up in a topic before. Some people, before doing biopsies, do MRIs, and the substitute for that for identifying tissue issues, very clear, okay? But in the end, it doesn't totally replace a biopsy in the end. It's more validation of a biopsy. Is that correct?
We like to say that you have to have a very specific test in order to be confident enough to treat based on the test results. You need to be very confident that it's a true positive. And right now, neither MRI nor micro-ultrasound today is specific enough to let you do any kind of treatment without having that tissue.
Yeah, because in the end, getting a tissue sample for additional evaluation for ADT testing or Terra AI.
Yeah, you're absolutely right. And lots of other
right?
useful things with the tissue as well. Absolutely.
Yeah. Okay. Thank you. I very much enjoyed the presentation.
Thank you for coming by. I have a few questions. Will we be seeing you and will we be seeing Exact Imaging at the September Prostate Cancer Research Institute conference in September?
I don't know that one.
Okay, then I have a reason to send to info@exactimaging.com some contact info.
Please do. You can even send it directly to my email address, Neal.
Because Prostate Cancer Research Institute is the nonprofit arm of prostate oncology specialists in Los Angeles, big fans of color Doppler MR ultrasound.
That's fantastic. Yeah. We participate in a lot of conferences every year, and I'd be happy to add that one too if you'll send me the details.
I might have already benefited from your technology. Is it built into the Precision Point transperineal access system?
It is compatible with the Precision Point transperineal access system. Yes, it is. It's not built into it, but it's compatible.
I just had a biopsy with Precision Point. Maybe I've already benefited from it.
You absolutely may have, yeah. Those guys are really fantastic. Have you had Matt Alloway on to talk to your group?
I'm going to turn that question to Dr. Metzger.
I'm sorry, I missed the question.
I've been in touch with him, actually with his representative.
Sure.
He is going to pick one of the 3 days we have left in this year. So
he's fantastic and a really great speaker. I highly recommend him.
Good. All right. Looking forward to that as well. Thank you, Brian.
There's so much new stuff coming. It's hard to know who to get, when to get them. It's just, this has been great, Brian. This is exactly what we had hoped for, and it's going to look good in our video library and help an awful lot of men.
Fantastic. Can I ask you guys a question while I'm here?
Please.
I don't get to talk to patients very often. Can I ask you what the most important problems you think in prostate cancer are?
I'll start with Dr. Metzger, then go to Ira, Brian.
All right.
I'll go last.
Maybe I'll stop sharing so I can see.
Yeah, let me go to Dr. Metzger first, and then I'll go to
Neal,
Brian and then Ira.
What was the question?
What do you think as patients are the most urgent needs in the field of prostate cancer?
The way technology is advancing and with the precision microsound guided SBRT that you're going to develop.
Yeah.
That's a given with this kind of technology. You ought to be able to, and you don't have to be in the gantry with the big old MRI and all that stuff. But I think what we're seeing is education of the patient. People just not getting the proper workups, and they're getting too many no's from their whoever decides what things they can have, and they just come with improper workup, and it's just not necessarily the technology, it's just getting the information to people. If they knew
Yeah.
that this micro-alpha it could be done, most people would, because it's so much cost effective and so much easier, but it's just withholding the ability to do these things. When we get somebody that's really worked up properly, it's a joy. It really is. And the UC, we're lucky because in Orange County we have UCI, Hoag, City of Hope, UCLA, and not too far down USC. It's just amazing the technology we have available and the research, but it's amazing also how few of our men seem to get that technology unless they're directed to it. And too much fee for service in the private practice office. That's all there is to it. You get a fee for doing a biopsy the way you do it, and you don't get a fee if somebody else does it better.
Yeah,
So
there is a proposal in front of the CPT committee to change how
I'm
that's
sure,
done
I'm
right
sure
now.
there is, and I wish you well going through that system, because that's not an easy chore. But
Yeah.
thank you so much. This has just been one of the better talks we've had.
Russ, I think you had your hand up there.
I just wanted to add something to what Dr. Metzger just said. And the example is, friend of mine, I am a cancer patient, and friend of mine was just diagnosed with PSA spike. And the next question was, I guess I'm going in for a biopsy. And I said, they didn't do an MRI scan to evaluate it. And I said, go ask for that. They asked for that, and then after evaluating, look at PIRADS, whatever it is, the answer was, you're just going to be on surveillance. It's really doesn't look like anything. But the example is, I'm telling a friend about that, and the doctor isn't. And some of this has to do with what we might call the void between Denver, Colorado, and California. I don't know, but it's just constantly mentioning it to it. And I would also summarize to say things like prostate awareness and breast cancer awareness are nowhere close to each other yet.
Yeah.
10 years, 15 years behind that, where people aren't going to talk about it and they don't seem. So I don't know. The communication of everything that can occur or should occur, as Dr. Metzger was saying, it isn't time and time again.
Also, Russ, breast cancer is more upfront with their things than the prostate.
Nice touch.
As I said, Brian, you should hear him when he's playing poker.
That's great.
Great presentation, by the way.
I'll give you a little feedback that we are trying to address perhaps in this thing. Our mission is information, hope, education. When the group started 30 odd years ago, there wasn't any information. One of the problems now is there's too much. And part of what we're trying to do is to help guide people through the information, and information like yours, where we can focus it down to a 20, 30-minute summary of a presentation. You get in there if you're interested, follow through and something like that. That kind of thing makes it very much worthwhile. And just from a personal point of view, not what's important, but what's going to be important to me is I'm getting my follow-ups to SBRT through MRI. I looked at some of your slides and said, maybe I should switch to an ultrasound follow-up to see if there's anything floating around on the side. So thanks for that. Okay.
But post-radiation is a difficult space for imaging.
Yes.
I don't have a ton of pictures in my repository of post-radiation. I have a lot more post-HIFU for some reason. I think it's just the mix of the people doing our scans, but the bottom line seems to be more imaging is better in these cases.
Agreed. So thank you again. Yeah. Thank you, Neal.
Oh, quite welcome. If we have a little bit more time, Ira, do you have, I'm
Yes.
sure you have input. Please share it.
I always seem to. But this is a subject which I'm sure that you brought up with Dr. Klotz from your town. With focal therapy, the shortcoming of it is the imaging. And so
Right.
that's why it's not, I guess, CCN. It's considered investigational.
It's investigational. Yeah.
And in fact, I have some information here. There was a Dr. Ryder from UCLA who did a study about the MRI misses, and so according to him, 26% misses the GG3, 40% GG2, and if it's less than 1 centimeter, 80% of cancers are missed. There's an opportunity for this section to improve it. So I think that's something that your machine or another machine could find.
Yeah, I agree. I'm very bullish on focal therapy. I think it's come a really long way and done very well in all of the longer term follow-up studies now. It's very difficult to move past the investigational stage because prostate cancer is a very long disease. And it's difficult to show that it controls the cancer as well as radical prostatectomy or radiation over you have to wait a long time to get those results. And we're just starting to get some of them, but there was a very good debate at the American Urology Association meeting this year about it. And I think it's gaining much more acceptance mainstream. And I agree that one of the main needs in that space is really good imaging, really confident imaging, both for guiding the therapy initially and for the follow-up afterwards, because it's not a curative therapy. There's surveillance needed after focal therapy.
And, and just along the same lines, I know of there's different men, but I personally know of one man who had a MRI and it didn't show anything. And he's going along happy and this and that. And then all of a sudden he decided to have a biopsy. And he wasn't so happy then. So maybe if he had the micro test, that might have helped. I don't know. Or you can improve on it so it would help.
Yeah, we're trying to be as sensitive as we can.
I know you said it wasn't
so that doesn't
statistically significant, but it was
higher.
It's better. I wonder, how large was your sample size?
It was about 680 some odd men.
That's good size.
It was a good size.
Yeah. And was it at multiple institutions?
20 institutions, I think, across 8 or 9 countries.
Okay.
Mm-hmm.
Then that was with urologists determining that.
No, 2 of the sites were led by radiologists, actually.
Okay.
But mostly urologists.
I wonder if there was a difference between the radiologist and the urologist as far as...
We've never shown a difference between them. Once they're trained, they both do very well. Radiologists are very interesting folks. Not very many of them specialize in ultrasound. Even though they dedicate their lives to interpreting medical images, most of them are more used to reading CTs and MRIs than they are ultrasound. There's a small subset of radiologists, the interventional radiologists, who tend to do more on the ultrasound side that pick it up very quickly. They certainly learn it very fast. But I think once you've learned it, the radiologists and urologists both do extremely well.
Anybody else? Larry, any question, anything that you feel we need to start stressing or that has been your experience?
I guess I would like to make a little bit of a comment about ancient history. My prostate cancer started back in December 2008. So in 2009, I was scurrying all over the place to get imaging. And just to give you an idea how far you fellows have come and the technology, I went to see Dr. Bond up in north of Los Angeles, and he did an ultrasound exam. And he said that I had extracapsular extension here, there, and everywhere. So then I went to UCSF and got in on their trial for the MRI, and they said that they couldn't find any extracapsular extension, but I had so much cancer in my prostate that they really couldn't say. So that's where things were back in 2009, and on the basis of those inadequate imaging equipment, I had to make a choice between radiation and surgery. The speaker tonight just blows my socks off at how much the ultrasound technology has come ahead, for sure.
Thank you.
Yeah, since the days of color Doppler ultrasound, and that's not the only old ultrasound out there.
No, there's been quite a few different ultrasound techniques that have been applied here. And they're all helpful. The contrast enhanced ultrasound has been big in the Netherlands and in some places in the United States, like Thomas Jefferson University has done a fair bit of it. And there was a big trial similar to Optimum just a couple of years ago on contrast enhanced ultrasound. And it didn't work as well as MRI. But maybe the combination of micro-ultrasound and contrast will work even better, or micro-ultrasound and elastography, or there's a number of these techniques that have been useful in ultrasound that hasn't been applied to prostate quite yet, or at least not in the right way.
Super. Does anybody else? Go ahead. I'm sorry, Larry. I stepped on you.
That's Ira.
Hi, Ira.
There's a technology, spectral. Is that something that could be applied to this technology?
Yeah, ultrasound has a very rich spectrum. So there's a couple of different spectral techniques. So MRI has a spectral MRI technique, which is similar to the one that would be done with ultrasound. There's also a Raman spectroscopy, which is probably more suited to the histology analysis once you've got a sample out. But yeah, there's lots of really interesting stuff. And we have some big research projects ongoing to see which ones are going to work well in combination with the micro-ultrasound.
Hi, Larry.
Yeah, I have a general question of our speaker. It's my understanding you're from Canada, right?
From Toronto, yes.
Yes, okay. Back in 2010, I went to the American Radiologist Conference here in San Diego, and they said that they had a committee and that they were working really hard to come out with a standardized radiology report.
Yeah.
It's been many years. There's no standardization. And I was wondering if in your country, in Canada, do you have a national standardization of the format of reports on ultrasound and on radiation, MRIs, that sort of thing, or is it everybody does what they want to do?
I wish I could represent my country better. But unfortunately, we're no better off than they try, but we don't have a big electronic medical records system either throughout the whole country yet.
I see.
Which is more surprising in our case, because with a government-funded healthcare system, a single-payer system, you'd think it would be a lot easier to do.
I see. The problem that I have run into is that as the imaging technologies developed, it was always, you would get the imaging through a trial. The radiology reports that you would get from the trials were, they went in there and they put the tail on the donkey for every lesion you had. Like I had 31 lesions. I put them on a spreadsheet and I put in I tracked the SUV max. And I also assigned different colors to the lesions depending on whether they were new, whether they were the same, whether they were growing, or whether they were going away. And I was able to do that until the imaging went commercial. This is speaking of the PSMA
PET,
CT.
yeah.
And when it went commercial, all you get now is their impression or their findings. They mentioned 2 or 3 big suckers, and you have no idea how your overall disease is progressing, especially when you're metastatic.
I would advise you to request your images.
I have it all, but there's just nothing there.
So if you have your images and you can view them on a DICOM, so that we do have a standard for medical imaging globally called the DICOM standard, which is probably the worst standard ever invented, the least standardized standard I've ever seen. As an engineer, it's very difficult to work with. But if you've got all your imaging, then you should be able to compare your scans. Obviously, you're not a radiologist and you'd prefer a radiology report. Yeah. You'd prefer a radiology report where somebody who's done 1 million of these tells you how to look at it. But at least for seeing how particular points on your body have changed, you can usually load up 2 different scans in some of these viewers, and they have little mouse overs where you can see what the SUV max is for each of those different points and see how they're changing over time.
Very good. And by any chance, have you had a chance to talk to Zero Cancer, the big, you have talked to them?
Absolutely, yeah.
They run a monthly support group leaders powwow once a month. And I'm sure that support group leaders through their system in the US and Canada would love to see the
I
presentation.
feel like I don't remember if I presented to them or if we arranged a different presentation for them. But
Okay.
we did a presentation on micro-ultrasound to the Zero group.
Was it recent?
Might have been a couple of years ago now. I don't remember. But yes, they're a great group of folks, and very happy to work with them whenever I get the chance.
To get away from micro-ultrasound for just a minute, one of my frustrations is that we're not getting in front of men age 50 and older. And where prostate cancer control needs to start is in high-risk groups as early as age 45, and generally at least establish baseline of PSA at age 50. I'm hoping there's going to be a group that's going to come along and say, hey, there's great potential in going into sports radio. We have about 2 or 3 radio AM stations here in Los Angeles, California, and there's Fox Sports and there's ESPN in various languages, various channels, and say, we'll do a 30-second to 1 minute, just urging men to get tested and maybe even promoting some of the better technologies, because so much of our field is using technology from 10 years ago.
Yeah, I completely agree. The ProBase trial in Germany has looked at this very explicitly and starting in younger men, and the results are really good. And I think it's, in my opinion, a lot of the fault lies with the US Preventative Services Task Force, which initially recommended against PSA testing. I had to argue with my primary care physician for a PSA test because all the family doctors have been told that they shouldn't be ordering it, unfortunately. And it's a real problem, and it's leading to men getting diagnosed much later than they should.
Exactly.
And if I had one thing I could change, it would be to get the US Preventative Services Task Force to increase their recommendation, because I think the family physicians and the primary care doctors really pay attention to what that group says, and it would make a big difference.
There are changes here in the United States, certainly with Robert Kennedy Jr. It might be good to contact him and say, hey, why are we fighting cancer so hard down the line when we could take a look at cancer when it's still in the gland, when it's still focal therapy treatable, and get ahead of this thing.
I don't have his number, but if I did, I'd give him a call.
Okay. I'll see what I can do.
There you go.
Gentlemen, is anything up, Ira?
With former President Biden, they followed the guidelines with him, apparently. And
Very sad case. I don't know the details.
We don't know for sure, but they claim that he hasn't had a PSA since he was 71 years old.
Which is very reasonable. But what was that PSA? We don't really know how it was followed up. It could be at a grade group. I think it was grade group 5 that he has, or Gleason 9 or something.
Exactly.
It could be a neuroendocrine cancer that doesn't produce PSA. It's very rare, but it happens.
Yeah, but it's 11 years. So. Remember that they changed the guidelines that you referred to in 2012. They stopped doing this, and there were a lot of urologists up in arms, and they were writing messages about these guidelines. And of course, more people were diagnosed with more advanced disease. Then around 2017, 2018, they relaxed the guidelines some, because there were plenty of people men who were diagnosed, and they still are, and it could be that President Biden, he may have been vice president when they did this, and he wasn't able to get this test because he was part of the administration or whatnot. Because he might have been vice president then, I think.
Yeah, it's very possible. We shouldn't really know the details.
I mean, of course, they say it would be a cover up. That's the other thing. But I personally think that he followed the guidelines.
Yeah, maybe it'll generate a little bit more enthusiasm for early detection.
Super. Gentlemen, anything else before we say good evening? I thank you all for joining us just before Memorial Day weekend here in California. Brian, a pleasure to have you here. We look forward to seeing you again. I look forward to seeing you again at 0. And I will get the information we discussed tonight.
Great. Thanks very much, Neal. And thanks very much, everybody. This was a real pleasure.
Thank
very
you.
much.
Good night, everybody.
Okay. Good night.
Good night.